Hello, everybody. Thank you for the invitation to speak with you today. My name is Julie Power. I'm a patient advocate and I have been living with granulomatosis with polyangiitis vasculitis since 2005. I'm very interested in the area of AI and in healthcare and research, so this subject is very close to my heart, and I'm just sorry I can't be there in person. So, without further ado, I'll try and share my screen here and hope that I don't have any hitches. So, we're talking about AI in healthcare and research. So the first thing we think about, like with AI, we start thinking about, like the risk perceptions. So in the general population, they will be risk averse, like if things are going well, then they don't feel that they have to take any chances, or everything is going good. So the population that is living with illness, they will be risk curious because they want to know if there's something that can be made better. But in a population that are living with rare diseases, we would be very much in the category of being risk positive. And I'll try and explain why. So just a few basic facts about rare diseases. There are about 7,000 different rare conditions. So that gives you an idea of why it's so difficult to have, people know everything about every condition. It's defined as, like a condition that affects 1 in 2,000 people. As a result of this, there's very much a lack of awareness within the healthcare professionals, never mind the public. These conditions are usually very difficult to diagnose because of the lack of awareness, and it's difficult to access expert care and difficult to access the appropriate medication. With vasculitis, these are, like I've looked up Google to see, what comes up with it, but there are around 20 different types of vasculitis. Globally, there are 20 to 30,000 people per million of the population are diagnosed with a type of vasculitis. However, the prevalence and incidence of the vasculitis can vary by type of vasculitis and the population studied. We're not sure what causes it. There's no definitive diagnostic tool. There's no cure. And there's a general lack of awareness in it in general health care. So how does this impact us in our daily life? So for a lot of us, we have a diagnostic odyssey. We are several years waiting to get a diagnosis. We've been presenting with different symptoms, and no one's really joining the dots, so to speak. And while we're, like awaiting a diagnosis, there can be a lot of irreversible organ damage, and organ damage can happen in the absence of treatment. Because there's so few of us, we feel very isolated, and because our diseases are very strange, have a lot of strange symptoms, it's very hard for people to understand. So our own families and friends, will find it very difficult to understand what we're living with. Because they're rare, there's not an awful lot of information out there, so a lot of uncertainty about, about now and about our future. A lot of people have to medically retire from work. So there's difficulty accessing appropriate care and treatment. So you can see there's a lot of physical, psychological and social impacts of living with the rare disease. So the risk versus benefit equation in rare disease is very different. So the big thing is, what is the patient interested in? And addressing the unmet medical need, as you saw from earlier, like we say, there are about 20 different types of vasculitis, but we really don't know how many different types there and the regulatory review needs to involve the patients very much so in the regulations that are involved. So there's a lot of development challenges. So development of drugs, development of services that would lead to appropriate and timely care, to more diagnostic tools, less crisis management, less organ damage and personalised medicine. So I have been lucky enough to be involved in several research projects, but I'm just going to talk about two to you today, just in the interest of time. So one was FAIRVASC, and it was a 3-year project. It lasted from 2020 to 2023, and we were a team of computer scientists, clinicians and patient organisations, and we were aiming to expand the knowledge of ANCA-associated vasculitis. Now I need to say this was like a proof of concept project. So we knew that there were several vasculitis registries throughout Europe, but these registries didn't talk to one another. So we thought, because we're dealing with rare conditions, if we could get these registries to talk to one another, then we would have a very rich, robust data source for finding out, where is there more types of a particular type of vasculitis, what drugs were people responding to, what were the main organs that would have been involved, different types of information that we really needed to find out. And by interrogating that data, maybe we would find particular biomarkers or particular traits that would make us more predisposed to certain organ damage or to flares, which would be when the disease becomes very active. So basically we wanted to develop a means for getting all the registries to talk to one another. Now alongside that, we did an awful lot of work with patient groups, working on the data protection impact assessment, code of conduct and standard operating procedure. Now where I say we had a lot of involvement with the patients, because we were using their data in the registries, we needed to explore what were their concerns about it, what were their feelings about it, were they in favour of it, what would they not be in favour of. So we did an awful lot of work on that. Generally we found that patients were very happy to share their information if they thought that it was going to improve things for them or for future patients. But there was, a lot of fear about sharing the data with private industry, private companies, and losing control of the data. We spent a lot of time defining anonymity and who has access to the data. There was a lot of work on making sure that the data was findable, accessible, interoperable and reusable, that's where the FAIR comes from. And to make this, whatever work we did in getting the registries to talk to one another, we had developed a handbook for onboarding, and we also developed an ontology to make sure that all the registries were talking the same language. Now, I'm pleased to say that the project was very successful. We did actually manage to get the registries talking to one another, and now we're in a position to try and get further funding to make sure that this carries on, that we can develop the research further. So the second most recent piece of research that we're involved in is called Paradise. And this again is a proof of concept project, and it's using evidence from previous projects that we've been involved in and looking at using AI to develop a tool to predict relapse and thus lead to personalised medicine. So this is something that's really important for the patients. we have a patient partner in the project, and we had we have a public and patient involvement group, and they are now in the position that individual members of that group are now attending the various working group meetings within the project. And the focus is very much on traceability and transparency throughout the project. So we find, you know, like I was talking to you about the previous project, the Fairfast project, patients really want to know what's happening, and be that good or bad, they want to know all the pros and the cons. It creates a feeling of trust, and it makes sure that everything is very transparent throughout the project. There's input to all the patient-facing materials, so things like consent forms is another subject that is very close to my heart, and I know there's somebody else going to be talking to you about this, but the really important thing is that it's informed consent, and that there's also made very clear that there is the right to withdraw. We're doing a lot of work on AI transparency notice, communication materials, the website, patient app user interface and documentation. There's patient perspectives on all the project activities, the results and the dissemination throughout. And then we have, you know, like other patient groups that will evaluate, you know, like and feedback on the acceptability of the Paradise clinical tool that will be developed. We also have co-authorship of the white paper and academic manuscripts on the use of AI and personalised medicine for AAV. So the take-home messages would be, you know, it's really important to have patient involvement, really important to have transparency, traceability, informed consent, and all of these will lead to trust within the team. So these are my contact details if there are any questions that you have about my presentation. I know Nathan knows this subject inside out, and we have worked a lot together, so he may well be able to answer some of your questions, but those are my contact details if you need to get in touch. And this has been very short and very brief, but I hope that it has been helpful to you. Thank you very much, and good luck with the rest of the event.